Alrighty, welcome to the talk on hammer-digit syndrome. My name is Ashim Wadera, and I'm currently in practice with Insight Orthopedics here in the Detroit metro area. First and foremost, I just want to thank Z and MPMA for allowing me to speak here. It's quite the honor. I have nothing to disclose. Here are my credentials. Here are the learning objectives for this talk. Biomechanical concepts leading to hammer-digit syndrome, your surgical options, and then common complications and how we can address them. So I often look at hammer-toe surgery and forefoot surgery, for that matter, as more of a surgical art. It's definitely one of the more tougher pathologies that we come across. You often will have a patient that after surgery that'll come to you and say, "Hey doc, the toe's too straight, or it's not straight enough. There's too much bend, not enough bend, stiffness, and other complications." And so, as a surgeon, it's your job to correct the deformity and pathology, but there's a very large level of cosmesis that's involved. I think as students, residents, and even young practitioners, we typically underestimate toe surgery. And if I could do rear foot surgery all day, that's what I would do. Unfortunately, I'd be out of business, and that's the case for most of us. So I think that a lot of us young docs tend to underestimate forefoot surgery and hammer toes for that matter. I think we often call all digital deformities hammer toes, and we just can't do that. You know, there's specific ways on how to fix each and every one of these, and so it's important to identify what the deformity is. For example, if I have a hammer toe, maybe I'll fix this with a PIPJ arthrodesis and a flexor transfer. Claw toe, maybe a hips teno suspension with PIPJ fusion, and then the mallet toe maybe just a simple tenotomy. So the three of these are completely different, and so it's important to classify them for what they are and not call every digital deformity that walks through the door a hammer toe. Development of hammer toes are quite complex, to be honest, and these three are the more common biomechanical causes of your hammer-digit syndrome. More commonly, we'll come across flexor stabilization, and we are all well aware of this. More commonly seen in your flat foot or your pronated patient. This is where the long flexors will take mechanical advantage over the interossei. And a real hallmark sign is seeing an adductor varus deformity of your fourth and fifth digits. Next is extensor substitution, more commonly seen with the claw toes or cavus foot. The extensors will gain a mechanical advantage overlying the lumbricals. And oftentimes during a gait exam, you'll see contracture or bowstrung extensors all the way through the gait cycle. And then there might be a level of a neuromuscular disease as well. And so it's our job to see this. And least common is your flexor substitution. This is when the flexors have to stabilize due to the fact that you have a weak Achilles complex. And so this can be caused by a over-lengthening type procedure or an old Achilles rupture. And so sometimes you'll have patients that need hammer toe surgery, but oftentimes they will also need maybe a flat foot or a cavus foot reconstruction. And so if I have a patient that needs both, oftentimes what I'll do is I'll fix the flat foot first and see how they do later on with their hammer toes. And so sometimes if you correct the deformity, the primary deformity, the secondary deformity, such as the toe deformity, may resolve on its own. This isn't always the case. I don't like to do rear foot surgery with toes if I can help myself. The rehab is already tough for the patient, and adding toes on top of rear foot rehab can be tough for the patient. And so I always try to explain to the patient, let's see if we can fix the toes by fixing the primary deformity first. It's very important to get a good history and physical examination, specifically in the HPI. You definitely want to be talking and asking your patient about any history of neuromuscular diseases, or if they are suffering from a neuromuscular disease, is there any sort of family history under your physical examination looking for any sort of callus patterns, whether it's you're noticing a callus pattern dorsally, the PIPJs, or the the submetatarsals. These are all clues for you as to what you need to address. Again, neurologically, are there any deficits? Are the reflexes intact? Are there any signs of neuropathy or neuritis? Obviously, you do not want to operate on a patient that doesn't have great vascular system. So that's also something you need to look at. But more common exam findings are going to be um, looked at through your musculoskeletal examination. So first and foremost, from a musculoskeletal standpoint, you need to look at this deformity and see, is it flexible or rigid? And so I do that by having the patient do both, have them stand, and then I also in the chair, I load their foot by performing a clicking and push-up. So while weight bearing, does the deformity reduce? Is this semi-reduced? These are all clues for you as to how you need to address this, whether it's conservatively or surgically. MPJ pathology. Is there any sort of hyperextension at the MPJ? Is there plantar plate insufficiency? Is there plantar plate disruption? If there is, you simply just doing an arthroplasty or PIPJ fusion may not correct the deformity fully. Even though you're able to straighten the toe out, the toe may still float, if you will, if the plantar plate is not intact. And simply just taking the K-wire and driving it past the MPJ and allowing it to scar down may not be the solution for this patient. So this is something that you need to address as well. Perform the Lockman exam during your exam to see if there's any plantar plate insufficiency. First rate insufficiency. Oftentimes you're seeing that these patients have hallux valgus component, hypermobility. And so you may have a patient that comes in and all they're complaining about is subsecond metatarsal pain, but they have a hallux valgus component and it's complete and very hypermobile. So, we all know that the primary problem is actually the hallux valgus. So you need to have that discussion with the patient. So oftentimes you'll see me doing a Lapidus or a first MPJ fusion when I'm addressing any of my toes. You need to rule out aroma. Is there a positive Mulder sign? And equinus. Equinus is huge for us. More often than not, maybe your metatarsal head pain is happening from the equinus. And so not every single metatarsalgia needs a shortening or a wire osteotomy. And that'll be a discussion for the next lecture. But if there's a equinus, you need to address that. And so you'll sometimes find me performing my forefoot procedures and adding a gastrectomy misrecession to it. It's not uncommon and something that you really do need to address. I always try conservative care with all my patients. And so I've found that with some of the more flexible deformities, toe straighteners do work well. They can be bulky for patients, but they do work well, especially for those patients that are not surgical candidates. I like crest pads for patients that have developed painful hyperkeratotic lesions at the distal digits. I'm always advising taller toe boxes for my patients. And then is the patient already in an orthotic or do they need something to help stabilize their foot? And so I'm always trying an over-the-counter orthotic or even a custom orthotic. Let's quickly talk about cortisone injections. Patient has sort of a capsulitis. Some people will inject the capsule, and I don't know how I feel about this. I have done it, but you sort of need to think about this for a second. Cortisone could weaken the ligaments, especially the plantar plate, and so maybe the deformity gets worse with these injections. I don't know, but it can happen. I do like Medrol dose packs. I tend to use Medrol packs in my practice quite often. And so if they are having that dull, achy, pain in the ball of their feet, I will try to do a Medrol pack versus an injection. Obviously, if there is an aroma, then I am injecting, but I try to use Medrol packs in order to try and save some of the soft tissue structures. So surgical treatment, there's a lot of options here. We see a K-wire fixation with first MPJ fusion. Here's you can use screws for any sort of revision cases. Again, here's another first MPJ fusion. Flexor tendon transfer. This is specifically showing the Girdlestone tailor. That's something we'll discuss here shortly. You have companies now that are coming out with more of a MIS type of construct where there's less dissection and you're able to transfer tendons without really transferring the tendon. Here's intramedullary implants, and then you can actually make your own intramedullary implant with the use of K-wires. So you have plenty of options, and I think sometimes this can be overwhelming for surgeons because there's so much out there. And I don't think there's right or wrong. It's really coming down to what you feel comfortable with. So moving on, let's talk about the flexor tendon transfer. I think it's quite underutilized, but honestly, I think this is a great procedure. You know, for your flexible deformities, if you have a patient that has a complete flexible deformity, there is no MPJ subluxation or hyperextension. There's no plantar plate pathology. The toe straightens out. When you load the foot, you can simply just perform a tenotomy in the office. I oftentimes will use a flexor tendon transfer for semi-rigid and rigid pathology as well. If you do have, again, plantar plate pathology or MPJ hyperextension, just simply doing a PIPJ fusion or arthroplasty may not fix it. And so if you add the flexor tendon transfer on top of it, it'll help to harness the toe down, keep the toe nice and straight, but also harness the toe down. I use this quite often with plantar plate insufficiency and chronic plantar plate tears. Again, this is a different talk for a different lecture, but you're going to see a reoccurring theme here with the flexor tendon transfer. Also, it works really well for when you do need to perform a wild osteotomy or shortening osteotomy to help prevent floating toes. So what's the rationale for this procedure? Well, for one, you're removing the deforming force, and it helps to reroute the tendon and make it more of a corrective force when you transfer to dorsally. I kind of look at it like a seat belt for your MPJ, and it works really well for harnessing of toes. So again, you'll have those toes that sort of drift, they'll cross over, and you can really dial in correction with the well, specifically the Girdlestone tailor in my hands, and I'll show you this here shortly. But I think it's a fantastic procedure. It is very underutilized. Um, you know, biggest complication with this is stiffness, but you'll even see with the literature that most patients do well. Many options for flexor tendon transfer. You can simply just wrap the tendon under the extensor tendon. You can split the tendon and use that as a seatbelt. You can take the tendon through the joint, and then you can also drill through the phalanx and pull the tendon that way. My favorite is the Girdlestone tailor. And so this is a slide depicting the Girdlestone tailor. So you just make standard hammer toe incision before you do any sort of dissection of the PIPJ. You're going to want to go ahead and harness the tendon first. And so basically, you come over medially, and once you're past the sub-Q layer, your nerve vascular structures are out of the way. And so I simply will just take the 15 blade and sort of skive across the plantar aspect of the phalanx. The first few times you do this, it can be tedious and it may take some time, but and you know, the more you do this, the better you'll get. You'll then see the flexor complex. The thicker tendon is the long flexor, and that's the tendon you're looking for. And you have to remember that the long flexor will go through the short flexor at the level of the PIPJ. So take as much tendon as you can, go as distal as possible, and then tenotomize the thicker tendon, pull it out. And then what I do is I'll clamp it and leave it, and then I'll go ahead and do the rest of my work. Go ahead and dissect the PIPJ, do my fusion, and then come back and then transfer the tendon. So what I do is when I'm ready to transfer the tendon, I will take my 15 blade and I will create two arms for this tendon down the central raphe. And you can see the third slide here on the right showing that. And then we'll pass one arm underneath the phalanx and then grab both arms with hemostat. And then what you do is you crisscross them, and this is where you dial in your correction. So at this point, once you have done your PIPJ fusion or arthroplasty of the K-wire in, you may notice, okay, the toe is still cocked up. At this point, I will then dial in my correction utilizing the flexor transfer. And then we'll simply take a 2-0 vicryl and sew the tendon down, and then lay the extensor right on top of it. PIPJ fusion works really well for rigid and semi-rigid deformities. Oftentimes, I am combining it with the flexor tendon transfer. There are many options for fixation. The question is this more predictable than arthroplasty? In my hands, I say it is. I've gone away from arthroplasty. There are definitely people out there that still do arthroplasty and do well with them. In my hands, I found that fusion is the way to go. And so, you have to question this: does arthroplasty create instability? You know, there are arthroplasty has been known to create malalignment, reoccurrence, and painful instability, and even flail toes. So I found that fusion in my hands has done really well, although the literature will say otherwise from a functional standpoint. I found that arthrodesis does create more of a desirable result in my hands. Many options for your PIPJ fusion. End-to-end fusion is what most of us are used to. There's the peg and hold that we've read about, and actually this is a very stable construct. However, it is tough to perform. There's a chevron fusion that my colleagues in Indianapolis wrote a paper on, and we'll discuss that here shortly. And that's sort of my go-to, and many different Hammertoe implants that can be utilized. So this is a paper that was written by Dr. Miller in Indianapolis. These are my fellowship attendings. Uh, and so this is a modification to the end-to-end arthrodesis. This creates a really nice superior contact between cancellous bone. It really allows you to correct the deformity in all three planes, really. And this is sort of a modification from the peg and hole. The peg and hole itself is a very, very stable construct, but it's tough to perform. And so so basically you create a chevron type of cut in the phalanx, and then you cut a trough to sort of match it in the base of the phalanx, middle phalanx that is, and it's more of a press and fit at that point. What's also nice about this procedure is that you can fixate this with a K-wire, and to create more of a natural bend in the toe, you can essentially just anchor the K-wire into the dorsal cortex of the phalanx. And that creates sort of a natural bend in the toe. And nowadays you have hammer-toe implants that are doing that. You have like 10-degree bend in a hammer-toe implant now. You can just create that yourself with this construct. Hips tenile suspension. This is again something that we sort of read about in school and stuff, but we never really utilize. And I think it's a fantastic procedure for your claw toes and extensor substitution patients. Sean Grambart wrote a great paper on this, great technique paper, and it's really not that complicated. Oftentimes, this is going to be combined with other procedures, but really, it's simply what you do is you make an oblique incision over the fifth and fourth metatarsal bases, more of a curvilinear type of incision. You can see the picture there at the bottom. And through that incision, once you get past your subculaire, you're going to identify the long extensor tendons, and you will essentially tenotomize tendons 2 and 3, let them go, and then take 4 and 5, tenotomize them, and then you will either transfer them to the peroneus tertius or the lateral cuneiform. If your tertius is small, then I advise you to just anchor them into the lateral cuneiform. But I haven't had any issues with this as far as anchoring into the tertius. And this works really, really well for your claw toe patients. And if they're flexible in nature, then that's all you have to do. But if there is a rigid component, then you may need to consider PIPJ fusion and maybe even a flexure transfer. But this does work extremely well for your claw toe patients. And I urge you to read this paper. It's quite easy to do. So let's talk about some of the literature here. So we discussed flexor tendon transfer, and like I mentioned, I think it's a great procedure. It's really underutilized. Both these papers have shown for flexor tendon transfer. Here on the left, this paper showing almost a 91 satisfaction for flexor tendon transfer. Here on the right, paper written 2007 in FAI showing 89% satisfaction with the flexor tendon transfer. So yes, you do hear some of the horror stories about stiffness and what have you, but the literature does support flexor tendon transfer. This paper is looking at PIPJ fusion versus arthroplasty, 89 digits, 39 arthroplasties, 50 arthrodesis with a 1-year follow-up. What's interesting is that the scoring systems all improved very well with no real difference amongst arthroplasty versus fusion. However, there was a statistical difference between sagittal plane alignment with PIPJ fusion, meaning there was better outcomes in the sagittal plane with PIPJ fusion, but from a functionality standpoint, from a patient perspective, there really was no difference. Again, I prefer arthrodesis over arthroplasty. It's a bit more predictable in my hands. Others may feel differently, but I like the arthrodesis. So what are some of the concerns and complications that we come across? More commonly, you're going to have patients complaining of stiff toes, and this is just something you need to talk to them about prior to surgery. You can try and mitigate this with physical therapy and flexion exercises in the post-op rehab state, but more often than they're going to have stiffness. Swelling is a problem too. More often than not, swelling is going to last longer than it takes for the bone to heal. And again, this is again something that you need to talk to your patients about. It's a very small compartment you're working on, and they will balloon up. Scar contractures can be a problem, and so you can try and mitigate this with, again, flexion exercises and physical therapy. Lastly, flail toe. Is this caused by just simply doing arthroplasty? I don't know. But when you come across this, great procedure is just revising this with a calcaneal autograft, fixing the toe where there's a void, place the autograft, and these patients do well. Lastly, unrealistic expectations. You really have to have a conversation with your patients about results. You can do a fantastic surgery for these patients. It looks great. And then over time, they may drift and the toes may drift. And this is just something that you need to talk to them about. Toes are not easy. One of the harder procedures that we do. I do need to thank my fellowship attendings for allowing me to borrow a few of their slides and allowing me to use some of their x-rays. Thank you.